Okay. All right. And we are live. All right, everyone. Thank you very much for joining us here for this live ASRA event, where we're going to be talking to some of the recent authors of ASRA News articles. Before we get started, one of the things that I wanted to highlight is that we do have our spring annual meeting coming up, May 13th through the 15th. Certainly, if you can join us in person down in Orlando at Disney, that would be absolutely outstanding. And if not, a virtual option is certainly available as well. In addition to the annual meeting, we are going to be having some events that hopefully will make this, an event to remember. There's going to be a morning run that's taking place Friday morning. Even if you are joining us virtually, this is still an event that you can participate in. And there will be more information coming out about how to join us via a Strava option. So with us today here, then, we have three fantastic panelists. And I think I'll allow them each to go around and introduce themselves. On my screen to my right is Dr. Tsui. So if you could go ahead and introduce yourself.
Sure, yeah. Thank you, Chris. My name is Ben Tsui. I'm one of the pediatric anesthesiologists and adult anesthesiologists at Stanford currently. And in the past, I worked in Canada with Dr. Vivian Yip in Edmonton. So I'm really excited to be here and discuss one of the tests that we're using quite often in Edmonton and in the past in Canada and also now at Stanford.
My name is Vivian. Oh, yeah. No, my name is Vivian, and I'm an anesthesiologist at the U of A hospital in Edmonton in Canada. I'm also the associate editor for ASRA News for the next 2 weeks before I hand over to Crazy Kobe, who's sitting right here, who's going to take over my role. And I'm really excited today to be able to invite Basil and Crazy Kobe to have a chat with us about their article on the epidural stimulation test, which I think is underused and is so useful. And when Ban was here in Edmonton, we certainly use it. I still use that a lot in Edmonton, and I know Kwesi used that without fail in Halifax as well, which I'm glad to hear about. So Kwesi.
I'm Kwesi Kofi. I'm an anesthesiologist, acute pain and regional anesthesiast. I'm the director of the regional acute anesthesia and acute pain at Dalhousie University in Halifax, Nova Scotia, all the way in the east of Canada. And we've been using the Tsui test in our institution, the epidural electrical stimulation, for confirmation of particularly for thoracic epidural catheter placement for almost 20 years now. We were pretty early adopter and taught all of our folks to use it. So it's used fairly widely in our institution. So we have a lot of experience with it. And I'm actually quite shocked, actually, when I go to conferences, when I speak to very renowned regional anesthesia experts and I say, "Oh, do you guys use Tsui test for your epidurals?" And people go, "What's a Tsui test?" So I think it's important to talk about it. I think more people should know about it. It's been around for 20 years.
No, this is great. I can remember we have not yet adopted this, but I can remember the one time that we tried to use it clinically. I was a resident and we had a visiting professor, and we decided that we were going to look really, really smart and, try to use this new test. It was a pediatric patient though. So we put the low lumbar catheter in, and we were going to thread it cephalad. And we just could not get anything to stim. Unfortunately, it took us far longer than it should have to recall that we had given muscle relaxant beforehand. So our efforts to stim really didn't turn out very good. And I don't think we looked as smart in front of the visiting professor as we had intended. But it was a good learning experience. Okay, so anyone who's listening, if you have questions along the way, please feel free to type those in, and then I will try to relay those to our authors. In the meantime, though, we have a fantastic video that they put together. It's just a couple minutes, But I think it does a really good job of kind of framing what they're talking about and the steps and technique associated with this, and then we'll kind of lead our conversation along. So,
Thoracic epidural
without further
anesthesia and
ado,
analgesia have been used for a variety of surgeries, but its utility has been limited by a failure rate in the literature of up to 30%. The epidural electrical stimulation test, also known as the Tsui test, can be a useful technique for confirmation of the location of a thoracic epidural catheter. Many techniques have been used to aid thoracic epidural placement, and every technique has its limitations. However, epidural electrical stimulation allows for objective assessment of the catheter position within the epidural space and the spinal level of the catheter tip. In addition to a standard epidural kit with a wire-reinforced catheter, a Johann adapter and a nerve stimulator are required. A Johann adapter is a small, inexpensive, sterile device that consists of a lumen with a male and female lure attachment on either end to allow for a column of fluid. Adjacent to the fluid column is a conducting metal hub which allows for conduction of an electrical current to the column of fluid. It is important to note that because the electrical current is conducted through the column of saline within the catheter and the epidural space, a stimulating epidural catheter is not required. After appropriate landmarking and skin preparation, a wire-reinforced epidural catheter is placed in the usual fashion. Then a Johann adapter is attached to the catheter hub. A syringe of saline is attached to the Johann adapter, and the catheter is flushed to carefully avoid air bubbles within the system. The guard is then removed from the metallic connector on the Johann adapter, and the cathode alligator clip of the nerve stimulator is connected to the Johann adapter. An ECG lead is attached to the anode limb of the nerve stimulator, and this is generally placed on the patient's lateral thigh. The amplitude of the nerve stimulator is gently increased until the patient senses an evoked response, and the evoked motor response is directly observed. The cathode alligator clip is removed from the Johann adapter, and the guard on the metallic connection is replaced. The epidural catheter is then secured in the usual fashion. An observed unilateral stimulation between 1 and 15 milliamps is indicative of a catheter that is correctly placed in the epidural space, and the level of the evoked motor response corresponds to the level of the catheter tip.
And I think with that, then the video is all done. Right out of the gate here, any of you panelists, is there anything that comes to your mind after having watching that, or anything that you want to point out of the gate?
Maybe I can start with this common question people ask is, would that hurt? The stimulation test. Actually, the stimulation doesn't hurt at all. I think nowadays, because we're using ultrasound more and more, a lot of new trainee, they're hardly using nerve stimulation. The sensation the patient when we're doing the test, they will feel the same, no different than when we're trying to stimulate brachial plexus. That the arm they move, they usually don't associate with any pain at all. But obviously, one of the cautions you have to, just like using peripheral nerve stimulation, if you crank up the current by mistake or something, yes, it will become generally a really rigorous motor response. But generally, it's not painful at all. I think that's the most common people ask about.
The other thing I think is there's a lot of misconceptions I think about the test. The other thing is I think that a lot of people think that you need a lot of specialized equipment to be able to do the test, like a stimulating catheter. You don't. Or that you need a specialized type of catheter. Really, any kind of wire reinforced catheter can do the job.
One of the other questions that I get is for people who use loss of resistance with air, then they often ask, what then happened? They can't flush the catheter with saline, pre-flushed it. And what I tend to say to them is then, if they do use the loss of resistance with air, then they can certainly inject saline after they find the space, right? And then that should still work. And it's important also that they have the correct nerve stimulator that actually goes all the way up to 20 milliamps. Yeah, otherwise they can't stimulate properly.
Yeah. Are there any cases where you find this more helpful than any others? Like, I guess in particular, I'm thinking like a thoracic case, a really high thoracic epidural. Do you find it's more useful in those scenarios, or lower thoracic, or even lumbar? Or is it just really helpful across the whole spectrum?
I would say in terms of the test itself, stimulation, lumbar, thoracic, even cervical will give you the definitive positive test. There's not much different. However, I think it's more indicative or more helpful because thoracic epidural or cervical epidural is less often performed, so the success rate is lower. So you can often say if you do lumbar epidural for labor, like you do it 10 times a day, and the success rate probably really, really high. So you can argue that you don't need extra equipment to confirm what you're doing. But thoracic is different. And also particularly if you want to guide the catheter from thoracic region to cervical. And actually, I know when I mentioned that, people think, really? But actually, prior to ultrasound stage, when ninja-scaling or other block is not that consistent, reliable, we actually flat the catheter from thoracic region to cervical to almost very rich the brachial plexus region. Then you can check the level, so you can guide it that way. Or sometimes we actually can guide on the catheter to on more right side, left side to be more focused stimulation. Those will be particularly useful. That I don't think any other tests like the waveform or other things can help you, because those are just tell you in the epidural space, not. But the stimulation test actually not only tell you in the space, but where is your catheter tip, either against nerve root or what level. So I think that's the most advantage of this test.
I agree.
And Ben, you when you were here in Edmonton, you did that a lot with peds, where you fed the catheter from the caudal space and all the way up, and you can actually in real time see where your catheter is really.
Yes, actually, this one I think most people actually pick up this test quickly. Is Harvard Boston children, they're using that. But obviously now with the ultrasound that emerged, that we actually divert our attention, that we spend a lot of time to develop further with ultrasound, particularly in pediatric now. Pediatric less than 2 years old, practically you can see the catheter with the ultrasound. So you can argue that the need will be subside because the other technology moves forward. But in general, the adult thoracic epidural still will be quite useful when using stimulation to guide it. We also using both sometimes. I am sure that even in peripheral nerves block we do. Sometimes we're using ultrasound most time, but when we have difficult cases, we do using nerve stimulation like lumbar plexus or any deep side. We use that too. I think same thing with epidural. When we have difficult epidural like thoracic epidural or cervical, will be useful, and particularly for training will be really useful. But one thing is I have to caution it is a lot of people just use it when they're not sure. Just like how we look at the EKG, you have to look at lots of normal to get a sense what is not normal. So in other words, if you have to, for sure, if for example, if you know the epidural going to in the right place, you do the test, then you know the setup is right. But you cannot just using, I'm not sure in the right place or not, and then this is the first time you do it. It's almost you're trying to do a difficult area of fiber optic, but this is the first time. So that is, I would say, this actually is counterproductive when you try to use it when you never used it before.
The other thing I would add is that it's very easy to be able to use it routinely because it's very fast to be able to conduct, and you can do it sterilely within the sterile space. So if you do encounter a problem, it gives you an opportunity to troubleshoot without breaking your sterility, because we use that little plastic guard, and then we get the nerve stimulator placed onto the Johann adapter and then removed, and we can just put the little cap back on afterwards, and it preserves the sterility of the field.
One thing is it adds to safety, I feel, that is because if you get, if you can stim at a very low current, that gives you an indication that you may not be in the you may be in the intrathecal space or subdurally. And also with intravascular placement of the catheter, again, it actually doesn't disappear with the test dose. So I do find that useful too.
Great.
Well, I was telling these guys earlier that we, somewhat recently had a case of an intrathecal catheter that we didn't initially recognize until after we had given the test dose, and this was a mid to high thoracic epidural. And in that case, even the small dose of lidocaine in our test dose certainly led to a couple interesting minutes, while we were managing a somewhat high spinal anesthetic. And this is certainly something that would, I think, save you from that sort of situation, which would be really nice. I was thinking of a couple of other indications. In some patients, they'll have spontaneous intracranial hypotension and have CSF leaks at a number of different areas along their dura. So I didn't know if this was something where you thought maybe you could insert an epidural catheter kind of low in the lumbar space, use your epidural stimulation to thread it up to, where maybe some of the imaging demonstrated the most cephalad lesion, and then kind of do an epidural blood patch while you withdrew the catheter. Is that, or for positioning a spinal drain too? I know sometimes we have difficulty positioning our spinal drains when we try to insert those for some of our thoracic aorta cases. I don't know if you've ever used it for those type of indications.
Yes, personally, I did use one, and actually they have a case report, I think case series report published in Canadian Journal of Anesthesia by a group person in London, Ontario. They do using this so-called using the epidural stimulation test to guide where to do the blood patch for this exactly the same indication. So if people are interested, I think they can just type in stimulation test guide blood patch. I think it will pop up in the PubMed. It do happen, but yeah. So actually we use it. But one thing is bear in mind that when using the epidural catheter to thread it and inject the blood, you have to be quick. Otherwise, the ischemic catheter will cut off quickly. So what you should do is once you put it in, cut down the length before you give blood, so there will be less resistance, so you can inject the blood. Otherwise, if you're acting a little bit slow, then the blood clot in the tubing is so hard to inject. That's my experience. So yeah, so it can be done.
Other things, just kind of in general, it seems like we are training residents less and less frequently to insert thoracic epidurals because of the predominance of some of the fascial plane blocks that we're doing. At your institutions, are you implementing any strategies to try to train these residents better in the placement of thoracic epidurals, given the lower numbers that at least we're seeing at our institution?
We've certainly had the same issues as far as finding opportunities for our residents to teach thoracic epidurals, because the numbers have I mean, we still do a lot of them, but the numbers have declined compared to how often we were doing them in the past, particularly because of the increase in laparoscopic surgeries. So many more surgeries are being done laparoscopically that previously were done open. We recently acquired a thoracic epidural trainer, relatively sort of moderate to high resolution trainer that has reasonable feel, that I think is helpful for residents, gives them a time to just focus on their technique and not have to worry about their patient as all simulation does, which I think is great. The other thing I would say is I think the test is helpful because without having as a practitioner, not having your hand on the needle, there is a lot of confidence that is gained from the memory of what those tissues feel like, and it will affect your confidence appropriately or inappropriately. The test helps to make that objective. So even if your hand wasn't on the needle, you'll have a better idea of whether that catheter can be reliable. The other thing I'd say is, though there's not great evidence for it, I still routinely use ultrasound for thoracic epidural placement, pre-procedural ultrasound routinely, and I find it very helpful.
Yeah, I think with the stimulation test, ultrasound is not mutually exclusive. The ultrasound definitely will tell you where's the midline. If you're difficult placement midline, you have to find first, and then gauging the depth of the lamina, so you'll be more confident put the needle right than too shallow, and then keep walking too shallow and create a false pocket. At Stanford, actually, we for us, we're getting less and less done. Basically, 2 reasons. One is that we do more vasopressor block, and second is the surgeon saying a lot of for us epidurals, they don't know working or not. But now with the test that we help, so what we now is that a lot of time we actually place with the regional team. So we teach them how they do it, and then we test it at the end. So I think it do help the confidence of the resident rather than have to second guess about the clinical effect, because clinical effect will be post-op, maybe it will be at night, they already went home, you don't get the immediate feedback. What I find is exactly what you say, that because you give you like immediate feedback. So sometimes the resident say, I get the feel but not crisp. I say, don't worry, flat the catheter, we stimulate. If not, we can just redo it again. So rather than have to pushing, then that actually I think will substantially reduce so-called the dual puncture. Because when you don't get it, you're not sure, you keep pushing it, and then suddenly you see some liquid coming out is quite distressing. Particularly nowadays, we also, a lot of people prefer using saline. Sometimes it's harder to tell is the saline or CSF. But with the stimulation test, I say, if you think this is a loss of resistance, if you're matching the pre-op ultrasound, the depth is about right, the catheter. And if you do stimulation and can tell, and actually sometimes it's important, the epidural not functioning well is when you try to flat 5 or 6 centimeter, you enter in T7, you think should be great for upper abdominal, but when you do stimulation test, you can see the leg movement or something, you know the catheter just died south to the wrong place. So then you can pull back a little bit to optimize your location of the tip to get a clinical effect.
Yeah, I find that very useful, that objective measurement. For example, if a patient just can't communicate with you as, about, whether there's a level or not, then I find that very useful because it's just objective. Yeah.
So I think the question people ask me, I ask myself too, I derived that is in 1998. If it's something good, why after 20 years still no one using it? But I think it's a combination of factor. Like in the old day, we're using cassette tape or VHS. Now we're using all the iPhone, iPod, whatever. So technology do displace the necessity. And I think one thing is a lot of time, even our trainee, they don't know how to using nurse stimulation. So immediately when we discovered this technique, long and whole, we just moved in ultrasound quickly in the early 2000. So then a lot of people, if you ask a lot of training, what is the current? They have no idea what current we should aim for when we get the catheter close to the nerve, or what do you mean by the pulse width? What do you mean by the current? What do you mean by the frequency? They have no idea. So I think, and also because this ties in more to physics, most anesthesiologists is good at physiology, but a little bit weak on the physics part. So I think that's the reason why the hurdle is when they asking about the current, no matter how many times we say it's so hard to tell, they don't recall with that. So I think this is the main reason. But yeah, so I think we may have to go back to teaching more physics.
So we have a couple comments now that have showed up, which thank you. We have one from Dr. Kali, who is agreeing with you guys that the use of ultrasound is certainly helpful with finding midline and the depth of the lamina when we're performing thoracic epidurals. And I would agree that that is something I've never been able to do. I know live guidance is something that some people can do, but for us, just kind of doing a pre-scan, marching out the location of the spinous processes, especially in anyone who might have some significant pathology, scoliosis, something like that, is something that we have found very helpful. And then Harry is asking, how do you compare the epidural stimulation test or the Tsui test with fluoroscopy?
I don't mind taking that. In answer to the first comment, not that we're talking about ultrasound primarily, but I would say in addition to that, I also mark out the where I'm actually seeing the interspaces. So it gives me a very clear target at the level of the skin, but before I start, even though you can't always see a posterior and certainly not an anterior complex. But I think that's helpful as well. Compared to fluoroscopy, the electrical stimulation test is missing one component of sort of the ideal test, and that's actually helping us actually find the space. It helps us to confirm that we're in the space, but doesn't actually help us find the space. And I think as far as that's concerned, fluoroscopy has got to be considered the gold standard for epidural placement. The problem is, at least in my institution, the availability of fluoroscopy is limited. There are only so many devices available. They're very cumbersome. Our block room is not shielded, so we couldn't use them in the block room. Even if we can gown patients, the room isn't shielded, so it's not appropriate for fluoroscopy. And in most anesthesia training programs, the training for fluoroscopy is quite limited, and the use of fluoroscopy in acute pain is generally quite limited. And I don't think most regional anesthesia and acute pain fellowships have a lot of exposure to the use of fluoroscopy, so people aren't familiar with it. I think it's a great technique if you have it. If I had a patient who I knew was very, very difficult and I had no other option, might I try to do that? Yes. But even if I needed it, I might not be able to find a place to do it or a place to use it. So it's just not, it's a lovely if you have it, but it's just not practical. I think in most situations, unfortunately. So we need to look for other things, and I think that's where the epidural electrical stimulation is very, very helpful.
I think it's the same thing with the what you're exactly saying, that not only is the facility limitation, but also in a lot of patient population that fluoroscopy is still X-ray. You cannot expose to obstetric patient or pediatric patient. You don't want to expose unnecessary X-ray. That's why you can see even in chronic pain, they primarily using fluoroscopy. Now they're moving on ultrasound. But bear in mind that the fluoroscopy, they do get better penetration with bone versus ultrasound. So you just have to relearn the tool. Now I think the question they ask actually say, how accurate is the stimulation test? But there were a couple of studies show that stimulation generally by infrared you can predict your catheter tip with plus or 1 or 2 level of the fluoroscopy in terms of where's the level. So obviously, if you think about, as I say, people get confused. The stimulation test, what we derive here, is based on completely same as the peripheral nerve stimulation. We know the limitation on when we're using nerve stimulation, peripheral nerve stimulation. The same limitation is exactly same as the epidural stimulation test. That means that it's a still secondary response, rely on the physiological response of the patient. Obviously, like for example, like Chris mentioned that it happens all the time. Yes, if you paralyze the patient, if they're under GA, you won't able to get stimulation because we rely on the physiological changes. That's why the current range is so big. You can say that 1 or 2 milliamp to 15 or 20 milliamp, because each person is different. Just like everyone, the blood pressure is different, so it's a limitation. So there's no difference because we rely on the physiological response of the patient. Obviously, if they have different physiological problem, they may respond differently. Like for example, when you're doing stimulation for peripheral nerve, you need slightly higher current when the patient under general anesthesia. Same thing with the stimulation test. But one thing I can say that the take-home message I would say, if you're using the test more often, once you get used to it, when you see a positive test, that means that you get a peripheral stimulation. I mean the like corresponding nervous stimulation. Your epidural I would say 99% going to work, and you know where's the tip. But if you don't see it, there's many reasons. Your nurse stimulation may be out of battery, you hook it up wrong, the electrode dry, or you paralyze the patient, or many reasons. Like for example, recently one of my trainee, I train a lot, and then suddenly they say, "Hey Ben, the machine is not working." I said, "What do you mean by not working?" And then what they do, they hook up an extension on the saline column. When you extend the saline column, you increase the resistance. Your nurse stimulation no longer able to generate enough current. That's why I always say like funny number, but actually not delivering. So in other words, when you see a stimulation, you know the epidural going to work. When you don't see it, there are many reasons why there's no. So positive test is a great thing to have. Negative test, you have to still rely on your clinical judgment, because maybe machinery or the patient machinery interface have problem. So
That's great. Any other pitfalls that you've run into, or not? I don't want to say tricks, but solutions to problems that you have come up with over the years to make this work more effectively?
Now, one thing I usually do is I check my nurse stimulation, make sure it works first. Okay. Secondly, a lot of nurse stimulation, you have to familiar your machine. A lot of machine that you dial some number doesn't mean they actually deliver it. It just tell you what you're trying to deliver. So if you crank up to 10, it shows 10, but actually look at the dot. Usually they green light, that means they deliver successfully, or red, that means that it's not disconnected or something. That's important. And you prime with saline, that's important. And yeah, then other than that, I think you just have to do something that you use the same system in a case that you know is working. Build your confidence. So in other words, you cannot do a difficult airway with the first time using fiber optic scope, doesn't matter what kind. But you have to use it for a few times. In normal patient, you know how to handle it. Then you can interpret properly, just like how you interpret EKG when you see arrhythmia. If you never see it, they all look the same, QRS compact.
Yeah, I think it's very important for people to realize, like peripheral nerve blocks, where nerve stimulation kind of is adding another layer of safety together with ultrasound and all the other techniques that we have. I think epidural stimulation test again is adding something to what we have. Sure, you can still do an epidural without ultrasound pre-scan, without the Tsui test, but ultimately you're just adding another layer of safety. You're adding another layer of outcome measurement.
The other, if you would want to call it a tip and trick, if you want, is usually when I'm flushing a catheter initially, so I'd place the catheter in the usual way. When I flush the catheter, initially it aspirated, of course, and then flush it. I usually flush it a little bit aggressively, and making sure that there's no air coming in. So I hold the syringe upward to make sure that there's no air in it, and I make sure that I flush it a little aggressively to make sure that there's not any air within the catheter. And then while I'm stimulating, I don't inject, but I just keep my thumb a little bit of pressure on the end of the syringe, just to make sure that there are any little bubbles within the catheter that they get compressed, and that helps to keep the continuity of the stimulation. I find that when I do that, I don't generally find a problem.
Another term I want to mention: a lot of people know about test dose. I think the science behind the test dose, I would say, is also not that great, but people using it because it's a simple thing they do. But epidural stimulation is similar, but less people heard about it. I think it's the hurdle about physics. In a way that as an anesthesiologist, we should familiar with all our tools, ultrasound, nurse stimulation. We should use everything. Like even when we do a peripheral nerve block, we're using pressure gauge or something. So we should using everything. I think you hit on right is the take-home message is you should do a few with the thoracic epidural, that using stimulation test, get used to it, and then when you need it next time, then you can use it more accurately. But nowadays, less and less thoracic. I think for the trainee, it's really important to reinforce what they doing is correct, and they get the feedback immediately is really not that helpful. I think if they put the catheter, they don't know, and then next day neither working or not working, they still questioning, versus they immediately give them feedback, this is likely going to work, and then I think that will be substantially will reduce their risk of not ineffective epidural or dual puncture, because then you don't push it, and then you can just thread the catheter and check it rather than just take the chance of just pushing more and then try to get a better loss of resistance. Because sometimes, particularly when we do a fair amount of lung transplant patients, sometimes after they have steroid or something, the ligament is not as tough. You still all bunchy, and then suddenly you get lost, you're not sure. But those people have 5 different chest tubes, you do a lot of positions, sometimes it's really hard to do. That I think is the important time that you thread it in and then do it, because you definitely don't want a intrathecal catheter and crash the blood pressure on the lung transplant patient just recover from the major cardiac surgery.
Now, it certainly sounds like in your hands that these are things that are going to increase your success rate, increase your safety profile. To anyone who's reluctant to adopt this, what do you think as far as added time or added cost associated with the added equipment?
Into the cost, I think that device, I have no conflict of interest. I don't develop that dual hand adapter. But basically, you can using all epidural catheter. But the main thing is just have to get the basics, that sometimes this is really helpful for patient. Extra few dollars of the device, extra time worth the epidural working or not. And also this will be important. You want every epidural put in, you can confidently talk to your surgical colleague. Yes, this will be working. We just have to, now I know it's going to work. We don't have to brass it with 15 cc of local anesthetic, hopefully catch it the right level. That's the important part, because I see a lot of people when they're not working, they flush a lot of local, and later on they find that both legs become numb. So, but if your stimulation is before and you know your catheter will be there, you can quickly tell your surgeon or your colleague, say, or pain team to say, the catheter just ran down south the lumbar epidural. Maybe this time you just have to using narcotic base instead of local anesthetic. Otherwise, the patient cannot move, cannot pee, drop the pressure before you get the abdominal pain control. So you're more educated and you can tell what is the next action. I think that's important. Guide your catheter, how to optimize it. If you talk to a lot of surgical colleagues, they don't like epidural because they say the epidural neither good occasionally, majority time drop the pressure or not working. So I think if you know the catheter tip, you can plan what to do. If the catheter too far from the site of surgical, change the narcotic. If it's right place, you're using small volume should work. If you're not working, pull it out, just saying that the catheter is not in right place. Fix it beforehand, or actually honestly tell our surgical colleague or pain service that the catheter don't work, just change the PCA, rather than they complain to the surgeon, say the patient suffer all night because of that.
Yeah, I agree. I think it is important, or it's very useful to actually establish if the epidural is working before the case, because very often they will have had heparin at the start of the case, and then you can't even reinsert your catheter post-op. Also, if it's like, say, it's like an 8-hour case, do you really want, say, if you're in the block room that day, do you really want to wait until the end of the case and just come in and say, oh, by the way, your epidural is not working, plan B. And also it's obviously beneficial for the patient. And I feel that the main barrier for many people is the actual getting the right type of nerve stimulator that actually stim at a higher current. But otherwise, it really doesn't take that much additional time. That like 1 minute or less is not really going to delay that 8-hour case. Yeah.
I think you get a good point. Sometimes we just getting too fancy, want the current. But actually, if you're using our nerve monitoring, monitor the train or fall or something, they always have a button you can do the so-called one hertz twist, and they have a dial you can change the current. You can use those. Those will give you sufficient current generating, give you a positive test. But only thing, it doesn't have digital display what current they delivering. But those any room, any OR room have that equipment, you can actually use that. So to me, basically, you just need one machine. Talk to your biomedical engineer saying that when you turn up to water volume, how high is the voltage it generate? Then you usually know. Or you can try with a working epidural. You can turn on every time you work within, when you turn to 1 or 2, when you turn the dial, then you know this is the right range. When you're too high, too low, I mean it's not working.
If you didn't use this when you placed the epidural, and there's been an infusion of local anesthetic going through the catheter, is this something that you could try to apply retroactively, or do you have to do it right with placement and only with saline going through the catheter?
The local will tend to decrease the amount of, increase the amount of current that's required to get an evoked motor response, and it may eliminate it completely. So it will decrease the likelihood that you'd have a normal test. So you can try it, but the reliability is definitely going to be affected by the administration of local anesthetic for sure.
Yeah, well, the same point is actually excellent point. If you do a stimulation test while you're local running, if you get stimulation test, it's actually quite paradoxical. When you do the local running and you get a stimulation within 2 or 3 milliamp, your local probably is not there. That means that you're intravascular. So you should watch it. Actually, at this scenario, is using negative test, positive test to say something wrong. Your local is not acting properly to numb the nerve. Where's local? Another thing people ask me a lot, can you do this stimulation test when you have done the spinal? Actually, it can. We've done a small case series of it. You can do it safely with the combined epidural, spinal epidural. In other words, after you place a spinal dose, you can still stimulate. Now, the reason for that, we stimulate nerve root. Just like when you do spinal, you can still stimulate sciatic nerve. That's the same theory. So a lot of people think that I using combined epidural spinal, I cannot use it. It's wrong. Actually, we're using that. Actually, we're doing a study to see when in this situation, combine spinal epidural, once you do spinal, you don't lose your epidural. How can we test your catheter? So this way you can actually test the catheter without using it when you're doing combined spinal epidural. And actually you can still doing, it won't affect it.
All right. Well, this has been outstanding. I don't see that I have any more comments. Is there anything that you want to leave people with as we go?
Maybe I do a quick 2-sentence conclusion. I think technology change. I think one thing is because people think about the current and something. So next phase will be hope that technology, have the AI, will just give us, hook it up and give you green light, red light, you're in the right place or not, or maybe display the level, then people will use it. Like as easy as the iPhone, other things that you don't have to learn the code to use it. I think that's the major barrier. We want clinicians focus on the patient, not focus on the machine. So we will work towards it now. Hopefully it will be happening, particularly I'm at the Silicon Valley. Maybe I talk to some company, they may be interested to do that.
Last thing I'd say maybe that the test is simple to do. It's fast. Once you have an appropriate nerve stimulator, the cost is very low. A Johann adapter is cheap. It's been around for 80 years. So to me, there isn't a lot of drawback for having a good, clear, objective test to confirm a procedure that we know is challenging and is very difficult to do after the fact. So if you can have clear, objective, easy to interpret, objective information quickly, why not?
Yes, absolutely. I feel that this is such a simple technique, and for the sake of patient care, and the best interest for the patient, I think we should employ that more, and actually just get more practice and be slick at it. And it really doesn't take that long if you have all the equipment to actually do this test.
All right.
I agree.
Well, fantastic. Dr. Tsui, Dr. Coffey, Dr. Ip, thank you so much. And I look forward to when we can see each other in person. Have a good night.
Absolutely. Thank you very much, Chris. Thank you.
Thanks so much for